So hello, good morning, good afternoon and good evening to all our speakers, chairs and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Kenichiro Suyama. Prof. Suyama is an associate professor in neurosurgery at the Fujita Health University, Japan. His clinical interests are focused upon cerebrovascular and endovascular neurosurgery. He is a board certified supervising neuroendovascular surgery and neurosurgical instructor, and we are extremely honored to have him today with us as a speaker for our webinars. And today we'll be talking about Flow Diverter Treatment Strategy for Aneurysm with Incorporated Branch. The speaker for the second session of today is our honorable guest from China, Professor Lei Ting. Professor Ting is the Deputy Chief Physician and Deputy Director of Department of Neurosurgery at the Sanbo Brain Hospital, Capital Medical University, Beijing. His clinical interests are mainly focused on cerebrovascular and skull-based neurosurgery. He is an invited faculty to several conferences and workshops around the country. He is also a noted author with several publications in various peer journals, and we are extremely honored and grateful to him for accepting our invitation to be a speaker at our webinars. And today we'll be talking about the role of oral bacteria in intracranial aneurysm formation. The chair for the first session of today is our honorable guest from India, Professor Anil Karapurkar. Prof. Anil Karapurkar is one of the most senior and famous endovascular neurosurgeons from India. He is presently consultant endovascular specialist at the Breach Candy Hospital, Mumbai, and he was the past president of the FTIN and Cerebrovascular Society of India. He has authored several chapters in many books and has published numerous articles in many reputed peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Suyama. The chair for the second session of today is our distinguished faculty from Japan, Professor Masaru Abiko. Prof. Abiko is the Assistant Manager of the Emergency Medical Care Center and Department Chief Manager in Onichi General Hospital, Japan. He has more than 20 years in experience in neurosurgery. He got his PhD from the Hiroshima University, Japan, and his clinical interests are focused on cerebrovascular and skull-based surgery. We are extremely grateful to him for accepting an invitation to chair the session of Professor Lei Ting. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Anil Karapurkar.
Thank you, Professor Raja, and thank you, the ACNS webinar committee, for asking me to chair this session. The first session is on flow diverter in intracranial aneurysms with side branches coming off from where the stent is to be placed. US FDA, when it gave approval for use of FDs, it was essentially for proximal aneurysms, for aneurysms below the posterior communicating artery. As time has evolved and techniques have evolved, more and more complex aneurysms, more distal aneurysms are being treated with flow diverters. But even today, use of flow diverter in distal branches remains off-label use. It is not really approved by the FDA. But having said that, today we find that more and more aneurysms can be cured if we use a flow diverter. And branch coming off either from the neck of the aneurysm, or say for instance there is a PCOM aneurysm and the aneurysm is very close to the PCOM, or what happens to branches of the MCA. So let us see what Professor Suyama has to say about what happens to these branches which are jailed when we deploy a flow diverter. Professor Suyama, all yours.
Oh, thank you. Thank you for the kind introduction. Today, I would like to talk about flow diverter with a particular focus on flow diverter treatment for aneurysms with incorporated branch vessels. In Japan, our hospital is the biggest one in Japan, and I am both certified neurosurgeon specializing in cerebrovascular disease. And in Japan, neurosurgeons perform both open cranial surgery and endovascular treatment. Over the past decade, endovascular treatments for aneurysm have increased, while microsurgery has significantly decreased. This trend is largely driven by the development of novel devices such as flow diverter and intracranial device. Today, I would like to talk about flow diverter. Flow diverter represent a paradigm shift in the treatment of intracranial aneurysms. Flow diverter has distinct advantages. First, endothelialization. Flow diverter works by reconstructing the parent artery and promoting endothelialization across the aneurysm neck. This results in a high occlusion rate and a low recurrence rate. Another key advantage is that they eliminate the need for direct manipulation of aneurysms, which significantly reduces the risk of intraoperative rupture. As a result, flow diverter therapy is often safer than conventional endovascular techniques. Flow diverter have significantly changed the treatment modality of unruptured intracranial aneurysm. As shown in the left pie chart, between 2021 and 2025, about 80% of intracranial aneurysm in our institution were treated with endovascular treatment, while only 20% underwent microsurgery. And as shown in the right pie chart, flow diverter have become the dominant modality of endovascular treatment, accounting for about 60% of cases. Intracircular devices such as the web represent about 30%, while conventional coiling techniques, including stent assist coiling, make up the remaining 10%. I would like to introduce our current treatment strategy for flow diverter at our institution. This slide shows our treatment strategy for flow diverters. At our institution, we use flow diverter as the first-line treatment for sidewall and fusiform aneurysms. And we use adjunctive coil embolization in two main situations. One is large intradural aneurysm, and second, aneurysms with incorporated branch vessels. In large aneurysms, coils are primarily added to prevent delayed rupture. For aneurysms with incorporated branch vessels, coils are used to improve the occlusion rate. If the branch vessel is small or in non-ICA aneurysm, flow diverter monotherapy may be considered. We also use overlapping of flow diverter in large aneurysms with necks located on the outer curvature of the vessel to increase the likelihood of complete occlusion. I would like to explain each of these points in detail. First, let me start with the simplest flow diverter treatment. Standard aneurysms are treated with flow diverter monotherapy. This is the case when no branch vessel is involved, as shown in case A. This is a 73-year-old woman with a large symptomatic left cavernous ICA aneurysm, and the aneurysm was treated with flow diverter alone. At the 1-year follow-up, DSA confirmed complete occlusion of the aneurysm corresponding to modified classification class 1. Recently, we have been using the modified CS classification to assess treatment efficacy by evaluating aneurysm remodeling. Next, I will explain a situation in which we use adjunctive coil embolization. The first situation is large intradural aneurysms. In these cases, we often treat the aneurysm with flow diverter placements combined with coil embolization. This strategy is intended not only to improve the occlusion rate, but also to prevent delayed rupture. The amount of coil used corresponds to about 10% of the volume embolization ratio. However, adjunctive coiling does not guarantee complete prevention of delayed rupture, and this issue remains unresolved. In particular, giant intradural aneurysms are associated with a high risk of delayed rupture. This is a 79-year-old woman with a large left ICA aneurysm. The aneurysm was treated with a flow diverter with adjunctive coil embolization. At the 1-year follow-up, DSA confirmed complete occlusion of the aneurysm corresponding to modified CS class 1. The other situation in which we use coil is aneurysm with incorporated branch vessels. In this figure, case B, C, and D on the left are classified as having an incorporated branch. An incorporated branch is defined as a branch in which adequate flow diverter position at the branch origin cannot be achieved, regardless of branch vessel diameter. In these cases, coils are used to improve the occlusion rate. If the branch vessel diameter is small or non-IC aneurysm, flow diverter monotherapy may be considered. This is the main focus of today's presentation, and I will discuss it in more detail. Multiple factors have been associated with incomplete occlusion after flow diverter, such as age, wide neck, morphology. However, previous studies have consistently shown that the presence of an incorporated branch is the most frequent cause of incomplete occlusion. However, favorable outcomes can still often be achieved in cases with incorporated branches. Previously, we reported factors associated with treatment efficacy of flow diverter in aneurysm with incorporated branch vessels. This analysis focuses on the aneurysms smaller than 10 mm. In aneurysms less than 10 mm, the presence of incorporated branch was the only predictor of incomplete occlusion. Age, neck size, and other morphological factors were not significant predictors. In this study, among aneurysms with incorporated branch vessels, adjunctive coil embolization was associated with a significantly higher rate of complete occlusion. In cases treated without coils, effective occlusion was achieved when the branch vessel diameter was small. By including additional cases, we identified new findings. Here, we present these findings. We analyzed unruptured intracranial aneurysms treated with flow diverter as the initial treatment between 2020 and 2024. The flow diverter used was a pipeline embolization device and FRET. All patients received prasugrel during the perioperative period with aspirin added when necessary. Complications were classified into periprocedural complications, defined as those occurring during the procedure or within 30 days after treatment, and delayed complications, defined as those occurring more than 30 days after treatment. At 1 year after treatment, DSA was performed for follow-up evaluations. Cases with complete occlusion were subsequently followed using CTA or MRA. Various cases with incomplete occlusion were followed using DSA. Predictors of treatment failure were analyzed in patients who had DSA follow-up of at least 1 year. In this study, aneurysm occlusion was evaluated using the OKM grading system. OKM grade D was defined as complete occlusion, and OKM grade D or C were defined as adequate occlusion. As mentioned earlier, in this figure, case B, C, and D are defined as having an incorporated branch. This definition applies regardless of branch vessel diameter when the flow diverter cannot be fully opposed to the vessel wall at the origin of the branch. This is results. The study included 32 aneurysms. About 80% of the aneurysms were smaller than 10 mm, while about 20% were large aneurysms. The mean patient age was 57 years. 57 years. Median aneurysm size was 6.6 mm. Regarding aneurysm location, the most common site was the paracrinoid segment, followed by the vertebral artery, cavernous segment, and supracranial segment. This slide shows the result of angiographic follow-up. At the last DSA performed more than 1 year after treatment. Complete occlusion was achieved in 75% of aneurysms, and the rate of adequate occlusion reached approximately 90%. Retreatment was required in 6 aneurysms, 2.7%, and most of these were large aneurysms. When we analyze the factors associated with incomplete occlusion, older age and the presence of an incomplete branch were identified as significant predictor of incomplete occlusion. This slide shows the overall angiographic occlusion rate. When the cohort is stratified by the presence or absence of an incompleted branch, clear differences are observed. Aneurysms without incorporated branch demonstrate significantly higher rates of complete and adequate occlusion. In contrast, both complete and adequate occlusion rate are reduced in aneurysms with incorporated branches. In the following slide, I will focus on this subgroup of aneurysms with incorporated branches. The figure on the right shows the distribution of branch vessel in aneurysm with incorporated branches. The most frequent branch was the ophthalmic artery, followed by the posterior communicating artery and the anterior choroidal artery. And about 75% of these aneurysms were located in the ICL. In cases with incorporated branch vessels, we compared aneurysms that achieved complete occlusion with those that did not. The use of adjunctive coiling and a small apparent artery diameter was significantly associated with complete occlusion. When cases with incorporated branch vessels were further stratified according to the use of adjunctive coil embolization, the occlusion rate differed substantially. In the group treated with adjunctive coiling, the both complete and adequate occlusion rate improved to levels comparable to those observed in cases without incorporated branches. In contrast, in cases treated without adjunctive coiling, the occlusion rate were further reduced, indicating inferior angiographic outcomes. And yes, thank you. The figure on the right shows the distribution of branch vessel in aneurysm with incorporated branches treated without coil. The ophthalmic artery was the most frequently involved branch. As expected, aneurysm arising from the ICA were predominant, accounting for about 70% of the cases. When the aneurysms with incorporated branch are treated without adjunctive coiling, infundibular-like appearance remnant at the branch origin often persists, as shown in the left schema, making complete occlusion difficult to achieve. Therefore, we focused on our analysis on cases in which adequate occlusion was obtained without coil embolization. This is the result. We found that smaller branch vessel diameter and non-IC aneurysm location were significantly associated with achieving adequate occlusion. Because of the limited sample size, multivariable analysis could not be performed. Smaller branch diameter and non-IC aneurysm are related with adequate occlusion. Next, this slide summarizes complications in cases with incorporated branch vessels. Periprocedural thromboembolic complication occurred in 44.1%, and intracranial hemorrhage was observed in only one case. This hemorrhage was caused by the vessel injury during advancements of flow diverter delivery wire. resulting in a small amount of subarachnoid hemorrhage. The patient remained asymptomatic. Delayed thromboembolic complications were observed in one case, and no delayed hemorrhagic complications were identified. Non-ischemic cerebral enhancing, we call NICE, was observed in 2 cases. Overall, the rate of permanent neurological deficit was 2.0%, and there was no mortality. When comparing the cases treated with adjunctive coiling and those without coiling, there were no significant differences in individual complication. However, when all complications were combined, the overall complication rate was significantly higher in the adjunctive coiling group. Incorporated branch occlusion was observed in 60% of cases, and only one case was symptomatic. The case is shown in the image below. This was a large VA union aneurysms treated with adjunctive coiling, in which the ICA originated from the aneurysm dome. Immediately after treatment, the patency of the ICA was preserved. However, 1 month after the procedure, the patient developed dizziness. MRI revealed a cerebral infarction, and subsequent DSA demonstrated occlusion of the ICA. Fortunately, the patient's symptoms improved with conservative management. When comparing cases treated with adjunctive coiling and those treated without coils, there was no significant difference in the rate of incorporated branch occlusion between the 2 groups. This slide summarizes our main result. In cases with incorporated branch vessels, adjunctive coiling was associated with a higher rate of complete aneurysm occlusion. In cases with smaller branch diameter and non-IC aneurysms, effective occlusion could often be achieved with flow diversion alone. However, it should be noted that adjunctive coiling tended to be associated with a higher rate of overall complication. We present a representative case. This is a 68-year-old female with a right ACA aneurysm. The aneurysms was treated with pipeline alone. Post-treatment DSA shows good wall position, and we were able to confirm that the device was well opposed to the origin of the branch vessels. When the flow diverter is fully opposed to the vessel wall at the origin of the branch does not need to be considered an incorporated branch, and favorable outcomes can be expected. So this is not the incorporated branch. At 1 year follow-up, DSA confirmed complete occlusion of the aneurysms with preservation of flow in the branch, classified as modified CSC class 1A. Here, we will begin presenting cases involving incorporated branches. This is a 50-year-old female with an ICA aneurysms. The ophthalmic artery originates from the aneurysm dome. The aneurysm was treated with a pipeline with adjunctive coiling, using a single coil. At the 1 year follow-up, the ophthalmic artery was preserved and complete aneurysm occlusion was achieved. According to the modified CS classification, this case was classified as class 1A. This is a 54-year-old woman with IC ophthalmic aneurysms. The ophthalmic artery is seen to originate from the aneurysm dome, as the aneurysm was treated with a flow diverter combined with adjunctive coiling, using only a single coil. Immediately after treatment, residual blood flow within the aneurysm was observed. At the 1 year follow-up, complete occlusion of the aneurysm was achieved with preservation of flow in the ophthalmic artery. This is a symptomatic large IC aneurysm in a 65-year-old woman with a primitive trigeminal artery variant arising from the dome. The aneurysm was treated with a flow diverter combined with adjunctive coiling. Coils were inserted with a target volume embolization ratio of about 10%. Immediately after treatment, residual aneurysmal flow was observed. At 1 year follow-up, the aneurysm was occluded except for the origin of the PTA variant corresponding to modified classification class 5A. And reduction in aneurysm height was also noted. The patient's ocular symptom completely resolved. Next, left side, I see anterior choroidal aneurysms. The aneurysm was treated with flow diverter monotherapy. Only flow diverter. At 1 year follow-up, the aneurysm is occluded with a residual infundibular-like appearance at the origin of the anterior choroidal artery. This is corresponding to the modified CS classification class 5A. Patency of the anterior choroidal artery is well preserved. These findings suggest that when the incorporated branch vessel is small, such as the anterior choroidal artery, effective aneurysm occlusion can be achieved with flow diverter monotherapy alone. This is a 71-year-old female with IC-PCOM aneurysms. The PCOM is of the adult type and has a small diameter. The aneurysms was treated with a flow diverter alone, and complete occlusion was achieved. Follow-up imaging confirms preservation of the PCOM. This is a PCOM. In cases with adult type PCOM, occlusion of the PCOM may occasionally be observed on DSA. However, it is generally asymptomatic. This is a case of MCA bifurcation aneurysm treated with flow diverter alone. The superior trunk was relatively small, and the flow diverter could not be adequately opposed at the branch origin. At the 1 year follow-up, progressive remodeling was observed, and the aneurysm achieved modified classification class 5A with residual flow around the superior trunk. One notable finding is that the M1-M2 bifurcation angle showed a more gradual configuration over time. This phenomenon is known as geometrical modification. As the follow-up period becomes longer, some cases show delayed treatment effects even if adequate occlusion is not achieved at 1 year after treatment. This is a 36-year-old male with an IC ophthalmic aneurysm. The aneurysm was treated with flow diverter alone. Also, adequate occlusion was not observed at the 1 year follow-up. Effective occlusion was achieved on follow-up DSA at 2 years. This is a case in which adequate treatment efficacy was not achieved. The patient is a 59-year-old woman with IC ophthalmic aneurysms. The aneurysms was initially treated with flow diverter monotherapy. However, no treatment efficacy was observed at the 1 year follow-up because the patient had a prior history of subarachnoid hemorrhage. Additional flow diverter was deployed. Nevertheless, no reduction in aneurysm size was observed at the subsequent 1 year follow-up, and surgical clipping was ultimately performed. Yeah. We consider the lack of treatment efficacy to be attributable to two main factors: the presence of a relatively large ophthalmic artery branching from the aneurysm and the fact that this was an IC aneurysm, in which the parent artery is fixed at the dural ring making geometrical modification difficult to achieve. However, as no aneurysms growth was not observed, continuous observation might also have been a reasonable alternative option. While adjunctive coiling has been reported to increase aneurysm occlusion rates, it has also been associated with increased system complexity, longer procedure time, and higher complication rate. Our results suggest that the same trade-off applies even in cases with incorporated branches. Therefore, adjunctive coiling should be reserved for cases in which it is truly necessary. When adequate treatment efficacy can be achieved with a flow diverter alone, treatment with flow diverter alone is preferable, I think. Treatment with a flow diverter alone can be effective in non-IC aneurysms and in cases with a small incorporated branch diameter. In non-IC aneurysms, treatment efficacy is considered to be largely associated with geometrical modification of the parent artery. Aneurysms located further from the dural ring tend to have great vessel mobility, which facilitates geometrical changes of the parent artery after flow diverter deployment, as illustrated in the figure. These angulation changes may enhance flow diversion and promote aneurysm occlusion. In addition, smaller branch vessel diameter appears to be associated with better treatment efficacy. In general, the ophthalmic artery tend to have a larger diameter compared with the anterior corridor artery or adult type posterior communicating artery. Consequently, aneurysms incorporating the anterior corridor or other type beacon are more likely to achieve adequate occlusion with flow diverter treatment alone. Based on these findings, our treatment strategy for aneurysms with incorporated branches are as follows. In general, ICA aneurysms are treated with flow diverter combined with adjunctive coiling. However, in cases involving the anterior corridor artery or adult type beacon, where the branch vessel diameter is relatively small, treatment with a flow diverter alone may be considered. For MCA, ACA, and VA aneurysms, treatment with a flow diverter alone is our preferred strategy. This slide shows tips for using coils in conjunction with flow diverter. For aneurysms smaller than 10 mm, we generally insert only 1 or 2 coils. For aneurysms larger than 10 mm, we again target the volume embolization ratio about 10%. Key point is not to overpack coils. Overpacking increases the risk of immediate branch occlusion. With a small amount of coil, the branch often remains patent, or even if it eventually occurs, gradual occlusion is less likely to cause symptoms and is generally acceptable. Finally, regarding overlapping flow diverters, in large aneurysms, with neck on the outer curvature, overlapping flow diverter deployment can improve metal coverage and is associated with higher occlusion rate. This is a 65-year-old man with a right IC aneurysm in the cavernous segment. In this case, the parent artery did not maintain a normal vascular configuration. For such lesions, we fully overlap flow diverters across the aneurysm neck. We overlap the flow diverters so that the aneurysm neck is completely covered by 2 layers of flow diverter. As shown here, complete aneurysm occlusion was achieved at the 1-year follow-up. Here, we summarize our institution's treatment strategy for the use of flow diverters. Where should we set the treatment goal for flow diverter therapy? Flow diverter can achieve a high complete occlusion rate and low recurrence rate. But the question is, does incomplete occlusion mean treatment failure? I think not necessarily. This is because the clinical significance of residual neck or dome filling after flow diverter treatment is quite different from that seen with coil embolization. In many cases, these remnants remain stable or even gradually progress to occlusion over time, without the risk of rupture or symptoms. This slide shows the obliteration status after flow diverter treatment. The graph on the right illustrates the occlusion outcomes based on the OKM grading scale. Retreatment was required in only 6 aneurysms, 2.7%, of which 5 were large aneurysms. All large aneurysms that required additional treatment showed post-treatment enlargement. In contrast, among aneurysms smaller than 10 mm, only one case required retreatment. The case in which surgical clipping was ultimately added as previously shown. Notably, even in that case, no aneurysm enlargement was observed. An important point to highlight is that OKM grade A and B, which are generally considered treatment failure, together account for 11% of cases. However, the actual retreatment rate was lower than this percentage. This indicates that lack of aneurysm shrinkage alone does not necessarily represent treatment failure. If no aneurysm enlargement is observed, careful observation may be an acceptable option. That said, the post-treatment course after flow diverter appears to differ between aneurysms more than 10 mm and those less than 10 mm. Large aneurysms may demonstrate post-treatment enlargement and should therefore be considered a distinct group from smaller aneurysms. These findings suggest that aneurysms enlargement modified CS class 3C occurs exclusively in large aneurysms, whereas aneurysms smaller than 10 mm are unlikely to regrow or require additional treatment. This is a case of recurrence following initial treatment with a flow diverter. The patient had ruptured large basilar SCA aneurysms, which was initially treated with coil embolization. Since SCA originated from the dome, SCA bypass and SCA trapping were performed to convert the aneurysm into a sidewall configuration. After then, flow diverter was deployed. At the 1-year follow-up, the aneurysms had enlarged and classified as modified CS classification class 3C, leading to placement of additional flow diverter. Currently, the aneurysm is gradually shrinking and is now classified as modified CS class 3A. So we are managing the case with careful observation. The goal of flow diverter treatment for unruptured intracranial aneurysm is not necessarily complete occlusion, but rather the prevention of rupture. Flow diversion may prevent rupture even when some residual filling remains, but that does not mean we can ignore all residuals, especially in large aneurysms, and delayed rupture in large aneurysms remains a concern. To conclude, flow diversion is both effective and safe not only for large aneurysms, but also for aneurysms smaller than 10 millimeters. In cases with incorporated branches, adjunctive coiling can improve the rate of complete aneurysm occlusion. However, when the incorporated branch has a small diameter or in non-ICA aneurysms, satisfactory occlusion can often be achieved with a flow diverter alone. On the other hand, adjunctive coiling tends to be associated with a higher complication rate. Therefore, the decision to add coils should be made carefully, balancing the potential benefit in conclusion against the increased procedural risk. Thank you.
Thank you, Professor Suyama. Your lecture has been very lucid. I have some questions. One is the question which is always asked. Do you do testing for antiplatelet therapy? You use antiplatelet aggregation, as the Europeans call it. So do you do testing systematically in these patients, and what test do you use for the antiplatelet effectiveness? Aspirin, clopidogrel, Brilinta, prasugrel, what is it that you use?
We always use prasugrel and aspirin. And we check the PRU by Verify Now. We adjust the dose of prasugrel by PRU.
Because we have not found, sometimes the Verify Now is not very reliable. So we are a little hesitant about using Verify Now. So we actually use the platelet aggregation test, which is done by the hematologists. We rely more and more on that. And prasugrel, use of prasugrel, have you had any hemorrhages, not intracranial, but elsewhere because of prasugrel?
Yeah. We only perform the PRU check, not anti-coagulation test. Yeah. We administer the dose of prasugrel is 3.75 millimeter in Japan. Yeah, so very low dose in the world, I think.
And have you had any occlusions, late occlusions with prasugrel? Stent thrombosis?
There is no instant thrombosis after treatment. Sometimes, but very low case, intra-procedure thrombosis occurred. But after treatment, we don't have instant thrombosis. I think PRU check is very important.
And how long do you continue the antiplatelet therapy for?
Dual prasugrel and aspirin for 3 months. And after 3 months, we stopped to administer aspirin. And after 1 year, we stopped to administer prasugrel.
I had one more question. Usually we have seen when the side branch is big and it is supplying a large territory, aneurysm often does not close and the branch also remains big. You seem to have had excellent results. You don't seem to have seen that. But we seem to see that.
The big side branch is, I think, bifurcation type. And our first choice of bifurcation type is intracranial device. And so flow diverter for bifurcation type is the rate of flow diverter for bifurcation type is low. So
but even at MCA, for instance, at the MCA, sometimes there is a branch which is coming off, and
Yeah,
you are forced to use a flow diverter with or without coils. And many
yeah,
times, if that branch which is coming off is big, the
yeah.
aneurysm does not close, nor does the branch. And we have
Yeah,
so
yeah, yeah,
occasionally we have gone in, we have put in a second FD, and then this branch which is coming off gradually shrinks, becomes smaller and smaller. But most of the times the patient has no symptoms. You don't see an infarct. But on follow-up DSA, that aneurysm disappears, I mean aneurysm remodels, and that branch disappears. Have you have that experience? Have you seen that?
yeah, yeah. If the branch is big, I think many cases the diameter of the branch gradually is small, but there is a risk of ischemic complication, cerebral ischemic attack, I think. So if flow diverter treatment for bifurcation type, the gelled branch diameter is small is good, I think.
You showed that patient with the cerebellar branch, which the ICA got occluded, AICA got occluded, and the patient got a
Yeah.
cerebellar infarct on follow-up.
Yeah.
But most of the time, because it is a very slow and gradual process, the patient develops collaterals
Yeah.
and they don't get an infarct. I mean, that has been our experience.
Yeah. Yeah. The rate of complication is low, I think.
Let's see if there are any questions from the audience.
Yes, there is one from Prof. Harshad Parekh who is asking how long will you give blood thinners and do you encounter vasospasm? The strategy to treat spasms.
Spasm, we don't have spasm. Spasm is by deployment flow diverter, but we don't have the case with spasm, I think.
And how long will you give blood thinners?
Blood thinner, antiplatelet, blood thinner
How
means
long?
Yeah,
yeah,
antiplatelet.
yeah, dual antiplatelet for 3 months after treatment, and after then, only prasugrel we administer, and after 1 year treatment, we stop to the prasugrel.
Okay. Thank you very much. One question if I would like to ask is like, what do you do in patients who have nickel allergy? Because most of the FDs you get in Japan have a very high content of nickel. So in patients with nickel allergy, what do you suggest?
We check the allergy test, and if the patient has allergy, we don't use flow diverter. Yeah.
Okay. Recently, we came across a report from Kanagawa, Japan, where Professor Tomoyuki Sumoto presented 3 cases about deploying flow diverters in patients with nickel allergy, and they used the Surpass Evolve, which has only 15% of nickel in the stent, whereas other LVs and other have around 55% nickel. So this is one strategy that I would like to suggest. Any questions from my co-host, Dr. Libun Singh?
Yeah, thanks, Raj. Thanks, Prof, for a very nice lecture. I have 3 short questions. One is you use the term adequately treated and also residual. How do you differentiate these two? How do you say it's adequately treated but it's not residual? My first question. Second question, Professor. You mentioned that you prefer to have a overlapping flow diverter for more occlusion. Do you think that by having a flow diverter with higher metal density is better or is less better than using 2 flow diverter in overlapping method? My last question, Professor. In your study, you found that the age is one of the predictor of poor occlusion rate. Do you think the age itself is a surrogate marker to the vessel characteristic? In actual sense, the vessel characteristic aging due to the aging process is the predictor rather than the age itself? Thank you.
Yeah. We overlap the flow diverter for the extradural. If intradural aneurysms, we use coil and only one flow diverter. And extradural large aneurysms with there's very wide neck aneurysms, we overlap the two flow diverter. Yeah, but we cover the neck completely by two flow diverters, not telescoping or overlap. Yeah, and next, the age is a predictor for incomplete occlusion, and the older patient has low power of end serialization. In less than 10 millimeter, the neck is very small, so end serialization is small segments needed. So, but if we involve larger aneurysms, age is important predictor. But higher age to add the coil, the or overlap is resolved to obtain the treatment efficacy, I think.
Thank you. Prof.
What about smokers? Do smokers give you any more trouble? Smoking. Smokers.
Smoker can be obtained treatment efficacy reported, I think. But in our study, smoking is not predictor of complete occlusion.
Thank you.
What about the first question of Dr. Liu? How would you differentiate between adequately treated and residual aneurysm?
Between adequate and
Very
one
good.
more time. About adequate occlusion is defined as volume reduction about 90%.
Okay.
Yeah.
Fine. Thank you. Thank you very much. We can go back. If Professor Abiko or Professor Leiting has any questions, you're welcome.
Okay. Thank you. Thank you very much for this excellent and very informative presentation. Of course, flow diverter treatment is undoubtedly a powerful option for us. But the concept of combination flow diverter with adjunctive coil is, of course, very practical, I think. But Professor said a little higher rate of complications. So, probably especially in you said type D and so on. Yeah. So, well, my question is, for example, how do you personally balance the indication between the flow diverter using and clipping, microsurgery clipping in this whole complicated, especially aneurysms?
For bifurcation aneurysms, our first choice is intracranial device. And if the intracranial device is difficult, we choose clipping. But for example, older patients and so to treat to patients to perform clipping is difficult. The flow diverter is the choice of the treatment. So flow diverter for bifurcation aneurysm is last choice, I think.
I see. Or using another intracircular flow diverter device, and so you use probably.
We use web. Web is the first choice for intracircular for bifurcation aneurysm.
Thank you.
Thank you very much. we can go back to our Honorable Chair to hear his concluding remarks.
Thank you. I think the side branch and aneurysm closure has always been a problem. If there is no branch, it is very easy, it is straightforward. When there is a branch which is coming off, it's always a problem. But I think Professor Suyama has shown us many cases, very nice cases. And in only one patient, he had this progressive occlusion leading to an infarct. But by and large, I think in most cases, we do get away. And we also personally, we don't use prasugrel. I don't like to use prasugrel. We use aspirin and we use Brilinta. And at 3 months, we also stop, but we stop Brilinta and we continue with the aspirin. And we continue it lifelong. So I think overall, the indications are gradually changing. And of course, in the acute situation, we try not to use a flow diverter, get away with coils and then bring the patient back and deploy a flow diverter at a later date, which is what Professor Suyama also had shown. So I think this is all I would say about the use of flow diverters in the side branches coming out from there. Thank you very much.
Thank you.
Thank you very much. It was indeed a very informative session. We learned a lot. Thank you very much. So we'll move on to the second session. Before that, I would like to mention that we are broadcasting this on YouTube, WeChat and Zoom. Thanks to Professor Shubin. And as of now, we have around 550 people who have logged in through all the different channels. So we'll move on to the second session. So we'll give this podium over to our second chair, Prof. Masaru Abiko, to carry on.
Good evening, everyone, and thank you for joining us today. My name is Masaru Abiko from JA Onomichi General Hospital in Japan. It is my great pleasure to welcome you all to today's ACNS webinar. To begin, I would like to briefly introduce the topic of our second session. Intracranial aneurysms have long been considered probably a hemodynamic disease. Yeah. However, probably accumulating evidence suggests that, for example, inflammations and infection may also play an important role in aneurysm formation and growth, and of course rupture. So today's lecture will probably focus on the emergency concept on intracranial aneurysms, pathology, and so on. So the second title is the impact of oral bacteria on intracranial aneurysms, presented by Professor Ray Ting. So, Professor Ray, please start your lecture.
Thank you. Good evening, ladies and gentlemen. I'm Lei Ting, and my mentor is Dr. Shi Xiang'en. I come from Sanbo Brain Hospital, Capital Medical University in Beijing, China. I feel honored to be here. I'd like to express my sincere gratitude to Dr. Xu Bin and Dr. Yuko Kato and Rajab for their kind invitation. I also extend my thanks to Professor Masaru Abiko, right, for the introduction. Thank you. Today, my topic is the impact of oral bacteria on intracranial aneurysms, morphological and molecular study. Now I will start my lecture. During the aneurysm surgery, it's really common to see that atherosclerosis frequently coexist with the patent artery or aneurysm itself. So we have this question: why this happened? What's the relationship between atherosclerosis and aneurysm, and what is the potential cause? So we have this question. So we try to search some papers on PubMed. First, well, about there's some image studies. It indicates that over 50% of unruptured aneurysm are accompanied by the atherosclerosis. And patients with atherosclerosis exhibit 1.7-fold higher incidence of aneurysms than this without this condition. And moreover, the atherosclerosis shows a positive correlation with aneurysm instability, and it suggests that potential role in evaluating ruptured risk. And there's another autopsy study. It shows 10 patients with aneurysm, and almost all aneurysms with present atherosclerosis in the aneurysm wall or parent artery or both of them. And even more, there's a study. They do the gene expression study. They compared atherosclerosis and aneurysm. It shows they have like a significant correlation between the atherosclerosis and the aneurysm. It's really, really interesting. Why this happen? Why they have similar gene expression, but it looks totally different, you know? So we keep going, keep to do the study and keep searching the papers on PubMed, and we found the significant correlation between both of them may be attributed to the similar pathogenetic mechanism. And here I have two pictures to show the pathogenetic mechanism. First, we can see the aneurysm part. Both of them, they have 3 stages to make this formation. First, about aneurysm, like smoke or hypertension, something like that, they will cause endothelial injury of the vascular wall. After the endothelial injury, and there's a lot of like information cells accumulation, like macrophages, nature killer cells, and this kind of inflammatory cells will secrete will release inflammatory cytokines. And all these cells and cytokines will cause inflammatory infiltration, and it will cause the extracellular matrix remodeling and cause the like vascular smooth muscle cells apoptosis. After that, and the artery wall and the structure will weakening, where weaken and lead to a gradual expansion and deformation. Under the hemodynamic stress, and it will result aneurysm and ruptured. So, and this is how aneurysm form, and we can see the another side, the atherosclerosis. It have a similar pathogenic mechanism. First is endothelial injury, like smoke and hypertension, something like that. It will cause endothelial injury, and after that, we trigger to release the adhesion molecules, and it will cause the monocyte adhesion to the vascular wall, and then the monocytes will transfer to the macrophages, and the macrophages will bite in eat a lot of like low density lip proteins to form cells, and release inflammatory factors like cytokines, inflammatory cytokines. And all these inflammatory cells and cytokines will promote vascular wall remodeling and plaque formation. So we can see these two pictures. They share similar like mechanism, but the result is total different, right? uh, we can see we know aneurysm. For aneurysm, the aneurysm, the artery wall is destroyed, right? Damage and the dilation. And but for the atherosclerosis, it's repair, right? It's thickening and plaque formation. So it's totally different. How this happen? And what the which factors cause this different, but similar procedure, but total different result. And so we keep searching the papers, and we found maybe macrophages plays a crucial role. We know the monocyte in the blood, in our blood, is inactive. It's called M0 macrophages. It's in a resting rate. But if something happened, and there's a lot of like various factors, it will cause the M0 macrophages transfer to different phenotype. For example, some like intracranial pathogens and TNF-alpha will drive M0 macrophages to polarize into M1 phenotype. And another things like IL-4 13 will promote M0 to M2 phenotype. And M1 and M2 phenotype have total different different mechanism. For M1, we can see here, M1 macrophages will promote inflammatory response and cause tissue damage, injured. But M2 is suppress inflammatory response, and it will clean up apoptotic cells and promote tissue repair and healing. So through these pictures, we can see, oh, okay, it's just explain the how aneurysm happened and how atherosclerosis happened, right? And but now let's come back to the atherosclerosis aneurysm. How it happens? Have two disease happen at the same time. And we have big question. Mostly the artery wall will be have the like M2 phenotype, and something will be M1 phenotype, but the aneurysm, the atherosclerotic aneurysm happens too, and something transfer to the M1 and something transfer to M2. They exist at the same time, and that make me feel very confused, and so we try to figure it out. How is there something special, or is there any special factors cause this? So we keep searching and keep to try to figure it out, and we found Pseudomonas gingivitis, the bacteria, may be the key point. First, let's see the performance gender virus, how it come to our body and how it work. The literature's research indicates that the performance gender virus can be like eat or bite by our vascular and serial cells and macrophages to form autophagism. And this autophagism is really tricky. It can be inhibited to the fusion of with lysosomes. It will prevent the degradation with cells and enable to survive in the cell for a long time. And thereby, it will achieve immune evasion. It transferred to autophagism. Okay, so what's the relationship with the macrophages about the macrophages polarization? And we keep searching the papers. We found this performance gender virus have come to the transfer to the autophagism, and it will become the factors and it will become an intercellular pathogen and act like a pro-inflammatory signaling, and it will induce M0 macrophages toward to M1 phenotype. So it will induce apoptosis in vascular endothelial cells and smooth muscle cells. And it will degrading complement C5 to induce apoptosis. So it can so we know through this picture we know that performance gender virus the bacteria will induce M1 phenotype, and it will cause aneurysm, right? But how about atherosclerosis? And so we have another picture. Through this picture, we can see that this tricky bacteria, the performance gender virus, it also can induce macrophages to transform to form cells, and it will accumulate polylate adhesion, and it will contribute to the development of atherosclerosis plaques. Also, it will promote MMP9 secretion. And MMP9 secretion, it will result the plaques tend to instability. So it will cause to the plaque not unstable, and it will cause inflaction. And also, there's several papers shows straight direct evidence that performance gender virus was involved in the pathogenetic of atherosclerosis and aneurysm. There are several studies identified that there is a significant correlation between dental or bacteria and the occurrence of atherosclerosis and intracranial aneurysms and subarachnoid hemorrhage. Also, there is an animal experiment further confirmed that oral bacteria can induce atherosclerosis. And moreover, there's some study shows they detect predental pathogenic bacterial DNA in both aneurysm tissue and atherosclerotic plaques. And some research even found the isolate viable live performance gingivitis bacteria from the atherosclerosis plaques. So all this finding indicates that performance gingivitis, this bacteria may play a remarkable the key role in the pathogenic mechanism of atherosclerosis aneurysm. Upon all this finding, and we hypothesized that the pathogenic mechanism of the atherosclerotic aneurysm about the performance gingivitis is like that. First, this bacteria will entry into our body, our bloodstream through our oral route, and this tricky bacteria will lead into transmit bacteremia, and the bacteria will subsequent colonize vascular endothelial cells and macrophages to form autophagism. And this autophagism will induce like inflammatory response and informational cells and informational circuits to in all this to enlarge the inflammatory response, and then it will damage the vascular endothelial and the smooth muscle cells. After that, under the blood stress and bloodstream stress, it will the vascular wall remodeling, and it will contribute to the aneurysm formation and the rupture. We try to verify our hypothesis. So we conduct a series of experiments to verify it, to find some evidence for our hypothesis. First, we think, it's bacteria, right? So we can do the bacterial culture and the NGS test. But unfortunately, we failed because we get the result is negative. We think because maybe it's the aneurysm sample is too small, because we know most intracranial aneurysm is smaller than 1 centimeter. So, and the sample we can take from the aneurysm is much smaller than them itself, right? So that's why we think maybe because the sample is too small, so we cannot find the positive result. We try to transfer to another study. Bacteria first, we think grandstanding is good for the bacterial finding, right? So we try to do the grandstanding on the all aneurysm samples. After we do this study, we feel so exciting because we found almost all samples have positive result. But after that, we found a really awkward things is most of the bacteria located in the non-tissue area. You can see here. You can see here. It's not in the tissue. It's non-tissue areas. That's really awkward. This really weird. So we think, something wrong, should be something wrong, right? So we try to review our protocol, and we try to review the whole procedure we do, and after that we think maybe something happened in the water sink, right? So we try to culture and do the gram stain on the sink water. Unbelievable. We found there's a large number of bacteria morphologically consistent with this we observed on the slides. So we conclude that all this positive result is unreliable because we cannot tell is a real positive or it come from the sink water, right? So we try to find another test to try to find more evidence. And finally, we found we can use the transmission electronic microscopic. It's we can see the much more details of the vascular, the aneurysm vessel wall, right? So but unfortunately we don't find any bacteria, but we found a lot of fixons. You can see here this autofixon is typically two double membrane structure in both the aneurysm wall and the macrophages. We found this autofixon and this special for this one, and it looks like there is a bacteria inside of it. So that make us feel, oh, nice. I think we found something positive. So we can try to find more, and we want to improve that this autofixon is come from the bacteria. So we try to use the immune gold staining to target LPS because Pseudomonas gingivalis, this bacteria is a gram-negative bacteria, so it should be include LPS, right? So we use LPS antibody to staining the autofixon. We found that there's a lot of immune gold signals inside of the autofixon. Since we found that, we can confirm the autofixon originate from the gram-negative bacteria, right? Yeah, it's come from it should be the bacteria autofixon. And during this procedure, some scholars and they publish some paper, and there's some authors they use the Pseudomonas gingivalis to infect the mouse, the coronary artery of the mouse, and after that they do the transmission electronic microscopic, and they found the Pseudomonas gingivalis bacteria inside the artery, and they found the autofixons too. Here you can see here the yellow arrow shows this is Pseudomonas gingivalis, the bacteria itself, and the blue star it shows the autofixon. That's really interesting because we found something really similar, like the Pseudomonas gingivalis, the bacteria in the intracranial, in the human sample, in the human intracranial aneurysm samples. Here, what we found, you can see here, these two guys looks highly similar, looks similar, yeah, almost the same. So that make we think, maybe this is the bacteria, this is Pseudomonas gingivalis, and we try to do more tests to verify our finding. We use qPCR. We try to take 58 aneurysm samples. We try to use 58 aneurysm samples to do the PCR testing, and it shows that more than 80% positive rate of Pseudomonas gingivalis DNA. So this study further confirming the presence of performance change virus within the aneurysm. We also conduct a positive control study. This is a 8 years old boy. He suffered myoclonic aneurysm of his superficial temporal artery. We do the surgery for him and we take the aneurysm out and we do the transmission electronic microscopic study. We found inside the aneurysm, we found this rod-shaped bacteria. You can see here, rod-shaped bacteria, and there's numbers, lot of abundant double membrane autophyxons looks like this, and within the aneurysm. So through this case, we know if there is a bacteria inside the aneurysm wall, it will form autophyxon. And we also do the confocal laser scanning microscopic. We found we found a lot of macrophages. Inside the macrophages, it has LPS antibody. And here you can see different colors. Yeah, this is macrophages, and inside this LPS staining. So it means the macrophages by the the bacteria. After all, we try to use different another things, another study. We collect blood sample from patients with aneurysms and healthy subjects, and we measure the level of LPS and the performance change virus antibody. Use ELISA. The result shows LPS antibody level were significant evaluate in aneurysm patient, but compared to the healthy subject, healthy people. At the same time, the performance change virus antibody level were markedly lower. So our findings suggest that more severe performance change virus infection accompanied inadequate antibody production may be associated with the pathogenetics of aneurysm. So it means, okay, this patient maybe have a really severe bacterial infection, but his body cannot produce a lot of antibody. So this kind of patient will have aneurysm. And after all, our study reveals potential mechanism for aneurysm formation. So we think but the performance change virus, the bacteria throughout the oral would come to our bloodstream and colonize the vascular endothelial cells and the macrophages to form autophyxon. And this autophyxon will cause like inflammatory activation, and there's a lot of inflammatory information cells like macrophages transfer to paralyzed to M1 phenotypes, and also it will secrete induce a lot of inflammatory cytokines to trigger a series of inflammatory response. And all this inflammatory response will lead to vascular wall remodeling and cause the aneurysm and ruptured. And this is the study reference, and that's all. Thank you.
Thank you very much for this very interesting and thought providing presentation. The professor's talk highlights so the biological complexity of the intracranial cranial aneurysms, and support the concept that inflammation and systemic factor may probably play an important role beyond the hemodynamic stress alone. This presentation provides very novel, I think, and important perspective, linking oral bacteria and intracranial aneurysm pathology. From clinical standpoint, probably this work suggests that aneurysm disease may not be a pure surgical or endovascular treatment alone problem, but also a systemic and inflammatory condition. Probably, although further the clinical studies are probably clearly needed, this work highlights an important further direction in aneurysm research, probably. I think so. Can I ask some
Sure.
questions? Okay. Yeah. How do you think these your findings might influence further clinical management, or, for example, prevention strategies for intracranial aneurysms? Further.
Okay. Yeah. Thank you for your question. And yeah, after I do this study and I try to clean my mouth 3 times a day, and also I try to do more clinical study. And every time I have the aneurysm patient, and I will ask, how about your teeth? And how do you clean your teeth? Like that? And I found more than 90% patient have tooth problem. Yeah. And some patients have a severe tooth problem, and really and so now I'm doing more study, and I try to collect some stone, the tooth stone, and to do analysis and to see how much the bacteria inside, and I try to do the animal study, and I use this bacteria to put inside the mouth artery, and and now we've finished the aneurysm model, and we found after 60 days, and it will cause looks like a small aneurysm, and also this small yellow part looks like atherosclerosis, and now we are doing the test. Yeah. I think in the future, and I will ask most people around me and my patient to clean their teeth every day.
Yeah, I think so.
And
Yeah,
try to make
probably
clean the stone. Yeah.
Yeah. So you think daily oral health management could reduce aneurysms growth or rupture rate?
Actually, yes. And in the future, I think I may use some some drug, antibacterial drug, like that, and try to, and I will build the animal model, and I try to use some drug to treat it. And I will see what will happen, and maybe it will smaller, or something will not keep going, become bigger. Maybe just stable or something like that. Let's see in the future. I don't know yet. Yeah.
Okay, thank you. So we can close now?
Yeah.
Yes.
Okay. Very, very interesting and surprising results of your study. We look forward to further research work done in this field to actually ascertain it is really the cause of the aneurysm, because it is very multifactorial. So, if I may ask, does smoking contribute to this proliferation of bacteria?
No, actually, no. I do a lot of research and I read a lot of paper. And after that, we think the bacteria may be the original, the original cause, original factor to cause the atherosclerosis. And we think it will cause the atherosclerosis first and then cause the aneurysm. And but the smoke may be destroy, maybe cause the endothelial cell injury or damage, and it will help. It will help to cause the atherosclerosis and aneurysm. It's not the original things, right?
Okay, thank you very much. So with that, we'll come to the end of today's webinar. I will close this officially now. On behalf of the Education Committee of the ACNS and the President Prof. Pato, I would like to thank both the speakers of today, Dr. Kenichiro Suyama and Professor Lei Cheng, as well as the chairs, Professor Anil Karapurkar and Professor Masaru Obiko, for the time and support for the ACNS webinars. A very special thanks to my co-host Liu Boon Singh for joining me today, and also special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 550 viewers online who have joined through all the different channels. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.